Hi, everyone. I'm Cynthia Toussaint at Women in Pain Nation. And today I am going to be doing a hot take interview. These are bite-sized conversations with women in pain and pain experts that speak to the lived experience of those of us with chronic pain. So it's October, which means that it's Breast Cancer Awareness Month. And in its honor, I'm going to be doing something special today. And you are all in for a treat. We are all in for a treat. Today, I'm going to be talking with Dr. Alyssa McManamon. Dr. McManamon is hard to say, number one. And she is a practicing hematologist-oncologist and a retired colonel. She is also the co-author with Dr. Wayne Jonas of this wonderful new book. And it's called Healing and Cancer, A Guide to Whole Person Care. And if you have pain and or a cancer diagnosis, you must read this book. And if you care about somebody with pain and or a cancer diagnosis, you must read this book. And if you care and are interested in pain and cancer, and you should be, you must read this book. So I think we've got a theme going here. Okay, before I introduce my lovely guest, I want to say that this topic is very near and dear because I have had high impact pain for it's October, so exactly 42 years in the form of complex regional pain syndrome and 19 overlapping conditions. And I fought triple negative breast cancer twice since 2020. My recurrence was in 2022. And after that first diagnosis, we spent a lot of energy for Grace with something that we call the pain cancer connection, because if you have chronic pain, you are more likely than others to get cancer because you have a lot of inflammation in your body. And if you have cancer, you're more likely than someone else to get at least one chronic pain diagnosis, because a lot of cancer treatments can cause chronic pain. And that being said, I haven't had a cancer treatment for a little over 2 years now, and it's been pain problem after pain problem. I'm on my fourth really serious problem. So this is a very serious topic, very important. Whole person in care is the way we have to go. And I'm really glad that you're here. So all of that said, welcome, Dr. Alyssa McManamon. Yay, there you are. Hi, nice to see you.
Hi, Cynthia. Nice to be here.
Thank you for being here. And I want to say, congrats to you and Dr. Wayne Jonas for this wonderful book. I loved this book. A couple of chapters triggered me a bit. We'll talk about that. But I just wasn't ready for the chapter about dying. So that should be, I should warn people about that too. And I respect and admire you and Dr. Jonas so much for being so ambitious to literally work to change the way that cancer care is being delivered, the way that pain care is delivered, and really the way that all of healthcare is delivered. Whole person care is the only ethical way to go. So thank you for that.
Well, thank you for your close reading, and appreciate all your comments. Yeah, thank you.
Okay, so I want to start with pain because I know that everybody watching has pain or loves somebody and is a carer for somebody with pain. So my first question is, what kinds of, we hate to go to like surgeries and procedures and drugs, we like to do with pain the least amount as I'm sure you do. So what are some non-drug approaches to pain that you would suggest patients exploring?
Mm-hmm. Yeah, I think, well, first of all, for people who are, in pain related to cancer, they're going to be offered pharmacological means to deal with that, which would be drugs often if it's from the cancer. And I just want to say that they may or may not be helpful to the person, or the person may or may not want those. So I think it's a legitimate question to ask what else we can offer outside of drug-based approaches. And we know that 53% of people with cancer at any stage are going to experience cancer pain or pain related to their treatment potentially at some point. And so when I think about the drugless approaches, I think about kind of two buckets. Like there's the passive things that can be done to us, and then there's maybe the more active modalities where we might actively do something. So if I could give examples, passive modalities might be things like people using biofeedback or using guided imagery where they're kind of listening to something that's online, for an example. That might be somebody using virtual reality goggles. And then a more passive mechanism might be that they actually are receiving massage therapy, or they're receiving acupuncture or acupressure. So those are kind of different ways to think about it. We know there's data behind use of things like acupuncture, particularly now we have guidelines that actually say that for women who have pain from aromatase inhibitor arthralgias, pain in their joints because of treatment for breast cancer that's estrogen receptor positive, that they can actually benefit from acupuncture for that. And that's part of the guidelines between the Society for Integrative Oncology and ASCO. So the data starts to mount on that we can look at drugless approaches to help people with their pain that might be related to the cancer or the treatment of the cancer itself.
That's really cool. And I have to put a big voucher in there for acupuncture. I did it before every chemotherapy infusion, and I did really, really well. So I love everything that you mentioned. Biofeedback is also really cool. Okay. So another question, how can patients who have pain or people with pain, I just say, how can we be better advocates for our health and well-being, being mindful of the fact that we women in pain are generally told that our pain is all in our head, we're hysterical, we have mental problems. I was told that for 13 and a half years before a diagnosis, and ever since. Any thoughts about that? How can we better advocate for our own well-being?
Mm-hmm. What I've learned from patients really that people who define and state their priorities like upfront about what they hope to get out of their life, out of if we're talking about cancer, out of the treatment for cancer, what they're hoping to move toward rather than just move away from, that can be super helpful to their care team. So I think when people look to advocate for themselves, part of it is just defining and really being able to state your own priorities to an essentially a stranger, right? You meet your oncologist or you meet, someone on the care team for the first time. It's almost like we have to teach people about ourselves. I've seen those patients do quite well because then I know how to approach them because they've almost taught me how to do that. And so I think of patients, even before I was getting involved with integrative oncology and learning about what all these modalities were, I really strongly remember patients who kind of came to me first visit saying, this is who I am. This is what I'm about. This is what you need to know about me to give you the best care possible. Because I was all about wanting to give them the best care possible. And so, they were kind of answering what we call the patient dignity question, which is not something that I made up, but what do I need to know about you as a person to give you the best care possible? People who just naturally kind of talk in those ways to their oncologist, they have a higher chance of getting the best care possible. And I think that I've learned that from patients for sure.
It's really interesting to know. Okay. So I want to move on to your wonderful book. So in Healing and Cancer, you recommend a number of times, you recommend having what matters conversations with the patients, not just at diagnosis, but all through their treatment. That blew my mind because I was never asked what mattered. I've been through, I realized 4 different major health hospitals, UCLA, USC, City of Hope, and now Cedars-Sinai. I've never been asked what matters to me. I've told my oncologist, but having CRPS, I've been dismissed a lot. I felt that I've always been abused for telling my doctor what I wanted. So I've had to go to outside doctors really to get care or interest in me. So it's been a really sort of an uphill climb. So I just love that part of the book. It really blew me away. So how as the oncologist, how does knowing what matters to the patient, how does that help you engage and support your patient in their own care?
Mm-hmm.
Does that make sense?
I think it makes care more efficient, and it also makes care. So, an example I've given before is if there's, a younger female who otherwise would have been counseled up and down about preserving her fertility, but she wasn't interested in preserving her fertility. She'd already been married for 10 years and wasn't trying to have a baby, and now had a new cancer diagnosis and still wasn't trying to have a baby. We can spend a lot of time giving people, like spoon feeding people information that it doesn't align with like their values or what they need. And that kind of takes away from the time of what they wanted to talk about or have questions about. So sometimes just finding out a little bit about a person before we even start, kind of spoon feeding or giving our spiel can be very efficient and can meet them where they are. So that's one example, if that's helpful.
great example. I love the idea of what matters. That's what I needed all along. Okay, great. So I love that you talked a lot in the book about loneliness and isolation. As women in pain, we deal with so much. I mean, I got sick when I was 21. My family and friends, literally, they ran for the hills. I mean, there's a lot of guilt and helplessness, and if it can happen to you, it's almost like it's contagious. And people just leave. We lose our careers, and I know, we're working a lot for Grace about on this same issue, loneliness and isolation. Times 100 when you go to the pain world. And I'm wondering if you have cancer and pain. I'm wondering if you have some thoughts as to how we can get reconnected when we're going through cancer treatment. Maybe we've had pain before, so we've lost that community. Any thoughts about that?
Yeah, I think it depends on the person in terms of like there's so many virtual communities, and that may speak to somebody as like, oh yeah, I would be very interested in finding out about that, and to some people that's a complete turn off. Some people are interested in sharing with people that they don't know closely, and some people aren't. So I think for people who are open to that world, who are, say, already in a sort of virtual situation with, they're on Facebook, they're on some of these other things, and they aren't like a heavy user, but they're open to it. Just letting people know that those communities exist is really important. And I think sometimes we don't give people like a resource list. Like, it's nice to have a resource list of, okay, these are legitimate patient-centered organizations that are online that have like a community that I would say is a safe place to go if you're looking for community. And that would be something that care teams could have on hand to share with people who would be open to it. That's one thing. I think the other thing, a lot of places do have peer support, sort of, where if somebody has gone through a cancer diagnosis, with or without pain, but they want to give back. I find that patients oftentimes want to give back. And so if we have a patient peer support sort of kind of list of people to call upon, sometimes we can do that on a one-on-one basis. And that takes somebody actually running a program and making that happen. But I know there's a one organization called Immerman Angels, and they actually connect just one person with one person. Most of that would be virtual because people can be across the country trying to find each other.
Right.
They can match people very closely, probably down to, does this person have chronic pain, prior to cancer diagnosis, and here's their cancer diagnosis. Can you find me a match? So those are some of the things that occur in more of a virtual space.
I love that idea. And I would just say, as a person who's had pain and cancer, for me, I was a ballerina before I got sick. I'm a mover, so I'm an avid lap swimmer, and I joined my local YMCA, and that community was critical to me when I first got diagnosed. And I mean, joining a church, having meaningful work, following our passions and meeting like-minded people. So these are a lot of ideas, because people with pain feel so lost. And then they get cancer, and they kind of sometimes give up. And I know that there are ways that we can find other people that care.
Yeah,
so I think you for all those ideas.
That's a great point about the YMCA, because their program is available not just to the person with cancer in terms of their Livestrong program. It gives you, a lot of those YMCAs give you a free membership if you're in that situation, and also to the caregiver, I've heard. So when I've called my local Y for a patient who is interested, they said, well, also the caregiver can come for free, which I thought was amazing. So it's building community, not just for yourself. That's great. You could bring somebody with you.
That makes me feel better, because I raised money for them too. And I love the YMCA. Thank you for that. Okay, so why is self-care important? And what are some of the methods that you really love? And I'm asking 3 questions, so I can break it down. But also, why is self-care important, not just for the patient, but also for the carer, and also for, I love healing the healer. Self-care is important for all of us. Why is that?
Yeah, it comes back, the good old saying, like, you can't fill someone's cup from an empty well. So as the provider who's seeing so many different patients, and as a team who's caring for so many people with various needs, we have to be able to kind of give from a somewhat full well, or a partially full well, not from an empty well. And, just to stay with the water metaphor, is such a simple thing, but just literally for all of us, cancer patients or not, staying hydrated, like how crummy and crabby we can get. I'm talking about me, right? If I don't drink enough water, because then all your systems aren't working correctly to get the toxins out, right? Because things get sluggish. So drinking water, staying hydrated, I don't care if it's water, just staying hydrated. And then one thing I learned actually in my integrative training was the power of movement, even just moving like once an hour. So, like we did this one exercise where, because it was all a virtual training. And so we were sitting there on the computer, but every hour at the last 10 minutes of the hour, they would release us for this one particular exercise day to go and do some sort of movement. I couldn't believe the change in my mood that day compared to the other virtual training weekends where we'd been on the computer without any of these breaks.
Yes.
And it was so instructive to me. So I, as a provider, I mean, I do try and get up and move around as much as I like to just stay on my computer and get my work done. And then, the last thing I would say is, again, this is just from my personal experience, like, taking a 6 to 8 month period to like eat a very big salad once a day. It had good and bad effects, but I'll say like what I noticed is that when we eat plant-based foods, it can help mood. And I didn't expect that. You read that, but then I really personally have experienced that. And I just thought, okay, it doesn't mean I still do that every day, but it was a good lesson to me. So I do always kind of believe that the research about plant-based diet, there's something to that if you've personally experienced trying to change your diet and see, do you feel different? In my case, I noticed there was a difference. And I believe that's something to do with the microbiome. And we all have the ability to adjust our microbiome based on what we're feeding it, because there's a lot in there that's eating what we're eating. And so it's just something to play around with if you have the ability to do that.
Yeah, so we are what we eat. And I actually was on the Mediterranean diet before cancer, and then I changed my diet to, well, I guess it's similar, but I eat fish about 3 times a week, and then everything else is vegan. And it's the most tasty diet I've ever had. I've actually gained 5 pounds on it. So yeah, it's so delicious, because food has, as you bring up in the book, food has to be, when I say I'm mostly vegan, people are like, oh, and it's like, no, I've never eaten so well, so that's really important that we know that it's delicious. Self-care feels so good, so yeah. So thank you for bringing that up. Can you speak a bit, without going into too much detail, about why internal environment is so important, not just for a cancer patient, but maybe as preventative care to not get cancer? Mm-hmm. Internal environment.
I mean, this is so tricky because people who have done everything right still get cancer. And I want to say that at the outset, because people who've taken care of their internal environment, in terms of if we're talking about the physical, like the really trying to eat well and do all those things, they still can get and do get cancer. And that can be really difficult because we can't make sense of it if we think it's all preventive.
Right.
But based on saying that it also can make us feel better, and it also can make us, potentially have prevented cancers we didn't know about that never came to pass. Yes. And I would say, the internal environment, we know there's the body as the larger, we can talk about the micro environment, the tumor microenvironment, say in somebody who has cancer, where the cells are directly there next to the blood vessels, next to the lymphatics. That's the local microenvironment to the cells themselves, or the tumor itself. That is just as influenced by our internal environment and all the nutrition and things we were just talking about, and really decreasing inflammation through both moving the body and, nourishing the body in ways that are anti-inflammatory. I think that, we have to realize that the very largest part of us, the very largest environment of our body inside this outside larger environment that we can't control, it does all have an impact on the very smallest sort of place within us that can be as small as the level of a cell. And so I think it's all connected. And you mentioned the word, I think in the pre-show, terrain. This has been a concept that's been publicized in the beginnings of integrative oncology, of course, and before that there's a terrain inside of us, and we want to make it inhospitable, as people have said.
Just for hostile. Yeah, I love that. I talked over you. I spoke over you. I apologize. I've been known to do that, okay, but I've been good so far. Okay, so I love that you brought up a patient's intuition in the book. Why is a patient's intuition important for best outcome?
I personally, I can't tell you out of a study why it would be important, right? But I know that I have an intuition about my own body and my own health. And so I carry that with me. And I believe that everyone has some sort of knowing about their own body and what does and doesn't work. That's why not everybody should be a vegan, or not everybody should be, keto or whatever, because everybody should do what they know kind of partly intuitively works for them and partly by their personal experience. But the intuition, my feeling is that it doesn't go away. It must be addressed, like what their intuition is. So if they say, they have a concern, or if they bring something up as something intuitively they're concerned about, if we just ignore it, or if we just move forward, kind of overstepping that question or that kind of concern, I think then it can become a barrier to the care actually being useful to the person, or to the person even engaging in the care. We've seen people who just walk away because they're being, their experience is that they're not being heard. And it's like their intuition is so strong that it almost becomes like a wall that they have to stand on, rather than being willing to listen even to the science and other stuff, so they can maybe question their intuition, because sometimes intuition can be fear too. We have to question sometimes parts of it. But as a patient, if you don't feel that you're being heard, it can be a barrier to really receiving care that's being extended.
It really is. And if you don't trust the doctor because they're not listening, it is a huge barrier to care. And I think it's sort of the nocebo effect. I mean, if we think something's going to hurt us, I think it generally does. And if we think it's going to help us, I want to tell a story. About 21 years ago, I was diagnosed with DCIS. So, and ductal carcel in situ. And I was told that by a doctor that wouldn't listen to me. When I had back then RSD, CRPS used to be known as reflex sympathetic dystrophy, and I wasn't listened to. About my concerns were not listened to. And I was told that I had about 3 months to live if I didn't do chemotherapy, radiation, and surgery. So I was horrified. I remember my neck cracked on the way home. And that night, my partner John was turning the light off, and I said, "No, let's keep it on," because I said, I remember saying, "I feel like you're closing my coffin." I just was so sure I was going to die. And I went out. I did something that you talked a lot about in Healing Cancer. I went out in nature. I went to a national park, Glacier National Park, and I took that road to the sun, that famous drive. And I had John stop at what I thought was the most beautiful place. And I just sat with myself and I just listened. And about 45 minutes later, when John checked on me, I had my care plan decided. And I'm going to say gesundheit, but I was totally at peace with watching and waiting. And 21 years later, I guess I'm still watching and waiting. So that was my intuition. My gut just knew that was the way to go, and it was the way to go for me. And thank God, thank goodness. Are you okay? Do you need a glass of water? I can probably
at the end of a cold.
Oh, I'm sorry. That's so hard. Even doctors get sick and they know what to do. I don't have too many more questions for you.
No.
What do you do when you can't stop coughing? It's the most horrible thing, especially if you're in a theater.
No, that's a beautiful example, though. Like you said, the outcome was coming to peace. If a person's not at peace, it's really hard for them to get through all the things that are being asked of them in the case of, say, a cancer that requires treatment right now. You made a decision that worked in your situation. Other people walk into situations where they agree to something that they haven't fully gotten to.
And I want to just, urge women in pain, whatever you agree to, you go home and you live with it, not the doctor. As well-intended as a doctor is, and probably is well-intended, you go home and live with your decision, and you say yes or you say no, and you are the boss. And thank you for saying that in your book, Dr. McManamon. Two more questions. Okay, so delivering whole person care is clearly the way to go. Now, I understand from reading your book that it's best done with a team. I never had a team. So how have you, as the doctor, how have you seen this to be true in your practice? Team whole person care.
Yeah. Pardon me. I was trained a long time ago, before team-based care was like a thing. And so I am still learning how to do this. And I will just say, honestly, I think that oncology is the perfect place to do this. And that's why we took a page from primary care, where they have, the primary care medical home. And now, there was the concept of the oncology medical home, that one person, meaning the cancer doctor, whether that's a radiation oncologist, a surgical oncologist, or a medical oncologist, cannot do this by themselves in a way that actually serves the patient, the caregiver, the extended family who have questions. We just cannot do that as one person. And so I think things are changing, and I see it particularly in the last 5 years, where really team-based care is the way things are going, where teams have multiple levels of providers, where you're going to have advanced practice providers working alongside and really supporting each other in terms of the physician and the advanced practice nurses and providers, physician assistants. And then we have, increasingly, we have improvement in our integration of, say, like mental health support within a clinic environment for oncology patients. That was unheard of, when I started. And so I think that's just one more example. The treatment room infusion nurses, they have always played a strong role in supporting patients. That's been true forever. And they've been asked to fill gaps that existed because we didn't have a full team. And I think we're starting to have more team members. And I would include, and that includes nutrition, that includes social work, that includes, exercise oncology or physical therapy, occupational therapy. We're moving into places such as prehabilitation. So offering prehab before somebody goes into a surgical situation for a very complex situation.
Wow.
That was not a thing, when I started. And so I really see the team expanding, getting bigger, and we're all just learning how to do this. And so I see it happening for sure, though.
What an exciting time in oncology. And it's an exciting time in oncology. I, as I mentioned, never had the team, but I made my own team because I finally found, I was told that I had a recurrence, and I asked for a CT PET scan that said I didn't. And the doctor still said, you have to have surgery. They didn't like that I didn't have surgery. And I said, well, thank you. I want a second opinion. You can't have one. Finally, I left. I fired that doctor. I went to another doctor. He wouldn't give me one. The third doctor finally said, I said, why? And why can't I get a second opinion? And he said, because whether you have a malignancy or not, you have to do surgery. So that's when I kept looking for a young female, and I found one, and I just loved this woman, and she really backed me up. She understood me. She was reading my book the second time I went in to see her. I'm like, this doctor wants to know me. And when she moved out of state, she said, let's just change our relationship. So she then referred me to another oncologist that I grew to really adore. Once he understood, you're not crazy. You have to be so careful because of, your CRPS. And he's retired, but those are really the two oncologists that I go to, that and a colleague that I won't mention. But it's Dr. Wayne Jonas, actually. He has really helped me. But I go to, and my pain doctor, who I trust completely. So I sort of had made my own team. And sometimes I work to get them all together, so we do shared decision making. And so that's kind of how, I think we can make our own teams. It's really hard. And if you're in a place of fear, which cancer care, it tends to be a fear-based environment. What you're saying is not so scary. But, it's something else I want to ask you about as I'm thinking of it. There's so much trauma with cancer. I care a lot about childhood trauma leading to illness, but I don't know if you want to speak about that. But also, when you have cancer, it's so terrifying. Like when I said I felt like John was putting the coffin on me, it's just like that's what I'd learned. It just was over. And every time I go get a scan, every time I get imaging, I'm terrified. I haven't survived 3 years, and which is the kind of the magic number that I'm told I need to survive. And that's so much trauma. And I'm wondering if you have any hints for surviving that better without hurting myself, because I know that's not good for my self-care.
Yeah.
It's a big question.
Well, I mean, I think medically induced PTSD is a real thing, whether, from just a diagnosis straight up, not given, in a way that was able to be, empathetically given, or can't be given empathetically because it's like a death sentence. When you hear the word cancer, it's just going to go
Right.
in one ear and stick in like that right here,
Right.
So I think medical PTSD is real. If When people have anxiety, I'm a big believer in the power of your mind, and as much as your mind can make you crazy, that there is the possibility to also sort of consider how to use your mind to get you in the right headspace to be in that scanner, say, and that might be self-hypnosis, because it's a powerful tool. It does require the time taken to do it and to learn it and all of that kind of stuff. But trying to say, what are my trigger points and how can I do something different next time? Because the way it is every single time, I know exactly how it's going to be. So how can I anchor that to something else and teach my thoughts to, or make myself script it differently, or make it mean something else, even if you're making something up, but to kind of talk yourself through in a different way, because you know what you're going to get. Is what I'm hearing. You're going to get the same thing every time based on, just the history of the experience. So how can you re-script that to change it, even if you're faking yourself out just to get through? I don't know. This is tough stuff. I think it's so individualized. I can't say exactly, but I think the first thing is to acknowledge, like you already have said, this is a real phenomenon. It's going to happen every time, and I'm trying to address it.
Just have to get through it. Right. Okay. That's good. Okay. I've got some new ideas.
There's an app called Calm Talk I don't know how it could be adjusted for what you're describing, but there's an app called Calm Talk, and I'm not a big app user myself, but during COVID, the anesthesiologist, I believe, who created that made it free for people to use. And so I have shared that with patients, about who have procedural anxiety or things like that. It's something to just try, because you never know if it will help.
Calm Talk, I like that. Okay. How would you recommend patients? I love the idea of patients being empowered. How would you recommend that we go about advocating for whole person care in our own treatment? And I'm wondering if you think that it's wise for us to bring in tools and resources that make the case for this kind of care, or do you think, more like my experience, that doctors might be threatened by that?
Well, it's good to find out, right? It's good.
There you go. Do and find out.
It's like the opening bell, though. You just want to kind of see, like what, if like, for example, here's how it could work without bringing something in, maybe in the first visit. If a person's being given a care plan and they're counseled about all the potential side effects from X, Y, and Z treatments, then the question could be, the patient totally understands those are all possible and they don't know if they're going to get them or not, and the doctor doesn't know if they're going to get them or not, but they could tell them how likely it might be, but still it's a little bit, we're not sure. And then the patient could ask a question such as like, well, I hear all these potential side effects. If I happen to get this one, which is the one I'm most concerned about, what could you offer me that would be like a drugless approach to try and, ameliorate that or improve that or even prevent that? Is it possible to prevent that? And just ask the question, because I think that gives you a pulse of whether your questions in that realm will be welcome or will be researched or what. And then if they're not, and you already have some self-education or knowledge, like, for example, Healing Works Foundation has a lot of pocket guides on different things that might relate to cancer or cancer treatment. And really, they are a safe place to find evidence-based approaches that, we would recommend out of guidelines and things like that. So if a person then went to the second step and didn't get their question answered, but next time brought something that was printed out, which is the example of giving something to your nurse or your oncologist, my finding is that, I can't ignore something if somebody gives it to me physically. Like, it's like, I actually look at it, right? I'm going to read it because I'm curious, because doctors and nurses are lifelong learners. We're going to be curious. We're going to look at it. And if it's evidence-based and informative, it might change, what I can talk to you about. And so I think sometimes, we do know from a survey that Healing Works did with IQVIA of about 1,000 patients and 150 oncologists or so, that one of the barriers to integrative care is that oncologists and care team members don't feel like they have the education base. They don't have the knowledge around these modalities to recommend them or not. They don't know. And so
That's
I think,
absolutely true.
yeah, you
I
can bring
found that to be
something
absolutely
in
true.
if it's educational. Yeah.
Yeah, I asked one of my first oncologist, my second oncologist, I went through a number of them. What do you know about integrative care? Yeah, just trying to get him talking with me. And finally I said, so what do you know about acupuncture? And he said, my college roommate tried it once. And it was like, this just isn't going to work. It just didn't work for me. So I guess I didn't bring anything in, but I brought in my education and my beliefs, and it just didn't work. So I thank you. I have gotten a rap sign, but I could not stop. I even got you coughing. This is a wonderful interview, Dr. Alyssa McManamon. Thank you so much for this. Thank you so much for your great work. Thank you for this book. I got to get up here again. Healing in Cancer, A Guide to Whole Person Care. Please, this interview is just about over, so you have my permission to leave and go to Amazon and buy this book now, read it, and then give it to your family, your friends, everyone you love, and then everybody else, because the whole world needs to read this book, because we have to change. We have to change medicine to whole person care. It's the only thing that makes sense. It is compassion. Thank you for your compassion. Thank you for your great work. Thank you for Healing Works Foundation, again, for this book. And thank you for being a healer. Thank you for this interview. I send you so much love. Thank you, Dr. McManamon.
My pleasure to be with you. Yeah. Thanks so much, Cynthia.
And thank you, everyone else, so much for joining me for this hot take interview. I learned so much from Dr. McManamon. I wanted to talk for another, at least, hour, but we didn't have the time. So in the comment section below, please tell me what you are already doing whole person care-wise that you didn't even realize was whole person care. I see this isn't so foreign. And then tell me what you're going to do different now whole person care-wise, what you're going to do as a result of watching this interview. And then we're going to keep putting this into this tape up again and again. Come back after you've read the book and you've given it to somebody else, loaned it to somebody else to read, and tell us what you've changed, because I'm guessing you're going to say so. We're not going to even have room in the comment section because you're all going to leave so many comments, and I can't wait to see them. And so again, Cynthia Toussaint signing off for now. Women in Pain Nation. Sending so much love and healing thoughts, and see you really, really soon. Bye-bye, everyone.